Welcome to the Week in Diabetes and Endocrinology from Hormone Insight. This podcast delivers a summary and perspective on the top news that endocrinologists, diabetologists, and internists can't afford to miss. This podcast is intended for healthcare professionals. For the week ending April 17th, 2026, I want to talk about a landmark trial of automated insulin delivery in type 2 diabetes that I think deserves a full airing on this podcast. An oral PCSK9 inhibitor that could genuinely change lipid management. What the SCORE trial actually tells us about dual SGLT1 SGLT2 inhibition. A new NEJM evidence trial of semaglutide in type 1 diabetes with obesity. Boehringer Ingelheim's strategic bet on obesity and liver disease, and a practical exercise study saying that when you work out may matter as much as whether you work out. Let's get into it. So I want to start with what I think is one of the more important diabetes trials of the last year, the 2IQ Plus trial of automated insulin delivery in type 2 diabetes, published in the New England Journal of Medicine. It's not a brand new paper, but it deserves more airtime than it's gotten, and the implications are still playing out. We've known for years that automated insulin delivery, what we call AID, works brilliantly in type 1 diabetes. That's settled. What's been less clear is whether hybrid closed-loop systems, CGM plus algorithm plus pump, actually deliver meaningful benefit in type 2 diabetes where the physiology is different, more insulin resistance, less catastrophic hypoglycemia risk, different economics. Here's the setup. 13 weeks, multi-center randomized trial, 319 adults with insulin-treated type 2 diabetes, randomized 2-to-1 to either AID using the tandem control IQ Plus system or to continue their pretrial insulin delivery, multiple daily injections or pump, with continuous glucose monitoring added. Both arms got CGM. The only difference was the automation. The primary outcome was change in hemoglobin A1C at 13 weeks. A1C dropped from 8.2% down to 7.3% in the AID group, a 0.9% reduction. In the control arm, A1C dropped from 8.1 down to 7.7, 0.3%. Mean adjusted difference, minus 0.6 percentage points, 95% confidence interval, minus 0.8 to minus 0.4, p less than 0.001, and time in range, the metric that actually reflects what a patient experiences day to day, went from 48% to 64% in the AID arm. In the control arm, 51% to 52%, essentially no change. That is a 15 percentage point swing in time in range from turning on the automation. That is a big deal. On hypoglycemia, the overall rates were low in both groups. There was one severe hypoglycemia event in the AID arm, so I want to be careful not to say there were 0 severe events. There was one, but the absolute burden stayed low, and we did not see the usual trade-off where pushing A1C down meaningfully drives up severe hypoglycemia. AID appears to decouple those, and that is the whole point of closed-loop systems. So Monday morning, when you see your patient with type 2 diabetes on basal bolus insulin, A1C stuck at 9 despite dose escalation, frustrated, missing doses, afraid of going low, this trial gives you permission to have the AID conversation. It's no longer just a type 1 tool. Caveats: 13 weeks. So we don't have long-term durability data. We don't have a formal cost-effectiveness analysis for US healthcare. The trial was industry-funded. Tandem paid for it. Tandem's technology was tested. So the usual grain of salt disclaimer applies, and the practical implementation is non-trivial. Your average insulin-treated type 2 diabetic in a primary care practice is not going to be set up on a pump overnight. This is specialist work. But the biology is now clear. Closed-loop insulin delivery works in type 2 diabetes. Story 2. This one, I think, is a genuine potential paradigm shift in lipid lowering. And this one is current and important. The phase 3 results for Enlicitide, an oral PCSK9 inhibitor, with analysis continuing to emerge through April. Let me make sure everyone's tracking. PCSK9 inhibitors, evolocumab, alirocumab, inclisiran. These are potent lipid-lowering agents. They crush LDL by 50 to 60%. They have demonstrated cardiovascular benefit, and they're used in patients with familial hypercholesterolemia, ES-PAVE style residual risk, or statin intolerance, but they're all injectable. evolocumab and alirocumab every 2 weeks, inclisiran every 6 months, still an injection. Enlicitide is the first oral PCSK9 inhibitor, 1 pill a day, small molecule. The CORALreef Lipids trial randomized 2,909 adults with either established atherosclerotic cardiovascular disease or at risk for a first event, 2-to-1 to Enlicitide 20 mg daily versus placebo for 52 weeks on top of background lipid-lowering therapy. Primary outcome at week 24. LDL cholesterol dropped 57.1% with Enlicitide versus a 3% increase in the placebo group. That gives you an adjusted between-group difference of minus 55.8 percentage points. A post-hoc secondary analysis pushed that to around minus 59.7%, but that is a secondary number. The primary between-group result is the 55.8. Either way, it's in the same range as monoclonal antibody PCSK9 inhibitors. Reductions were sustained through 52 weeks. 70.3% of patients on Enlicitide achieved an LDL below 70 mg per deciliter plus a 50% or greater reduction from baseline compared to about 1.5% in the placebo group. Safety was remarkable. Adverse events, 64% versus 62%. Treatment discontinuation for adverse events, 3% versus 4%. Serious adverse events, 10 versus 12%. New onset or worsening diabetes, 6% in both groups. Mortality, 0.7% in both, essentially indistinguishable from placebo for a drug that drops LDL by nearly 60%. Here's why this matters to us. Think about targeting LDL below 55 in high-risk ASCVD patients. If you're going from an LDL of 70 down to 45, you often need multiple agents, statin plus ezetimibe, then often a PCSK9 inhibitor. Right now, that last step means an injection. A needle-averse patient and many of our diabetic patients already on GLP-1 injections are running out of patience for more injections will resist. An oral PCSK9 inhibitor is a prescription, a copay, a pill next to metformin and the statin. The access barrier drops dramatically. But here's the crucial caveat. The CORALreef outcomes trial, the cardiovascular outcomes trial, has completed enrollment with over 14,500 participants, but we don't have those event data yet. Until we do, we can't definitively say Enlicitide prevents MI and stroke the way evolocumab did in Fourier or alirocumab did in Odyssey. The assumption is that LDL reduction is LDL reduction regardless of mechanism. But assumptions need data. If those outcomes hold up when they report, the oral PCSK9 class becomes part of how we treat high-risk ASCVD patients. Fast. Section 3. Sotagliflozin and SCORED. Let me set this up carefully because there's been some confusion. The SCORED trial was conducted in patients with type 2 diabetes, chronic kidney disease, and cardiovascular risk factors. Over 10,500 patients randomized to sotagliflozin versus placebo. The original primary analyses reported heart failure benefit, and those have been in the literature for a few years. A pre-specified secondary analysis published in the Lancet Diabetes and Endocrinology extended the MACE story, reporting that sotagliflozin reduced major adverse cardiovascular events, specifically MI, stroke, and cardiovascular death, by approximately 23% versus placebo. Why does this matter now? Because sotagliflozin is the one SGLT inhibitor that blocks both SGLT1 and SGLT2, whereas empagliflozin, dapagliflozin, canagliflozin are SGLT2 selective. The theory behind adding SGLT1 inhibition is that you reduce intestinal glucose absorption on top of the renal glucose loss, which may give better postprandial glucose control and additional cardiovascular and GLP-1 related effects. So the question practitioners keep asking is, does SCORED prove that dual SGLT1 plus SGLT2 is better than pure SGLT2? Honest answer, no. SCORED was placebo-controlled, not head-to-head against empagliflozin or dapagliflozin. A 23% MACE reduction versus placebo in a high-risk diabetic CKD population is meaningful, but it doesn't tell you anything about whether sotagliflozin beats empagliflozin on the same endpoint. To answer that, you'd need a head-to-head trial, and we don't have one. What we can say, sotagliflozin works in diabetic CKD, including for atherothrombotic events. For patients with CKD plus ASCVD, Sotagliflozin is a credible option, particularly given its heart failure pedigree. But don't tear up your empagliflozin or dapagliflozin prescriptions on the basis of scored. Section 4. This one is genuinely current and I think important. Published in NEJM Evidence, a trial of semaglutide in adults with type 1 diabetes and obesity using automated insulin delivery systems. Here's the background. About a third of adults with type 1 diabetes are overweight or obese. Insulin itself is anabolic. It promotes weight gain. And obesity in type 1 drives the same cardiovascular and metabolic complications it does in type 2. Historically, we've been hesitant to use GLP-1 receptor agonists in type 1. Worries about hypoglycemia, worries about diabetic ketoacidosis, labels saying type 2 only. This trial pushed on that. 72 adults with type 1 diabetes, obesity with a BMI of 30 or higher, all using automated insulin delivery systems, 26 weeks, randomized to semaglutide versus placebo on top of their existing AID regimen. Now, I want to be precise about the primary endpoint because it matters. The primary outcome was a composite, achieving time in range criteria, limited time below range, and at least a 5% body weight reduction. So this was not simply weight and A1C, it was a more nuanced glycemic plus weight composite designed for an AID using population. The semaglutide arm showed meaningful weight loss and improved glycemic metrics. The headline safety numbers, no diabetic ketoacidosis in either group, and severe hypoglycemia rates were similar between groups. But here's the clinically crucial finding. Total daily insulin dose in the semaglutide arm dropped by 22.6% over the 26 weeks. That is a substantial reduction. And it's the mechanism by which hypoglycemia stayed controlled. The patient eats less, absorbs glucose slower, needs less insulin. If you start a type 1 patient on semaglutide without a proactive insulin reduction plan, you will see hypoglycemia. So, the practical message, if you're going to use GLP-1 receptor agonists in type 1 diabetes with obesity, and the evidence here supports considering it for the right patient, you need to reduce insulin doses proactively. CGM and ideally AID should be in place. Close follow-up for the first few weeks. This is not a prescribe and see you in 3 months drug. On the guideline side, and here I want to be careful, the 2026 ADA EASD consensus on adult type 1 diabetes is currently a draft for consultation. That draft cites this semaglutide trial in its reference list, but I don't want to overstate it as a formal finalized endorsement until the final wording publishes. So the direction is clear, but let's not run ahead of the evidence. Section 5. Industry news with clinical implications. Boehringer Ingelheim announced this month that they are establishing obesity and liver health as a dedicated business unit. The pipeline anchor is survodutide, with a next-generation triple agonist peptide moving into mid-stage development. Why does this matter clinically? Because it tells you that the big pharma assessment is obesity and metabolic liver disease are not a temporary fad. They're durable, multi-drug therapeutic areas on the scale of oncology. Survodutide is a dual GLP-1 and glucagon receptor agonist. The dual mechanism is the interesting bit. Glucagon at the right dose increases energy expenditure, you burn more calories at rest, while GLP-1 reduces intake. So dual agonism hits both sides of the energy balance equation. Survodutide is in phase 3 for obesity, the synchronized trials, and phase 3 for MASH, the Leverage program. It carries FDA breakthrough therapy designation for MASH. Beyond survodutide, Boehringer's triple agonist peptide adds amylin or GIP or another axis on top of GLP-1 and glucagon. My take, we are moving rapidly from monotherapy, semaglutide, liraglutide, to rational multi-mechanism combinations. CagriSema, retatrutide from Lilly, already showing weight loss in the 24 to 28% range in phase 2 data. And now Boehringer putting real institutional weight behind survodutide and a triple agonist. The bariatric surgery equivalence question, whether we can get close to 25 to 30% body weight loss pharmacologically with acceptable tolerability, is going to be answered within 3 years. I think the answer will be yes. For practice right now, don't get too attached to any specific GLP-1 agent. The toolkit is rapidly expanding. Your patient who fails semaglutide may succeed on survodutide. Your patient with both obesity and MASH may benefit from a dual agonist in a way that pure GLP-1 blockade does not deliver. Last story. Rapid fire and practical. Published this month in Open Heart. A randomized trial of chronotype-aligned exercise timing in middle-aged adults with cardiometabolic risk. The question, does it matter when you exercise relative to your natural circadian preference, your chronotype? The trial was done in Lahore, Pakistan. 150 sedentary adults aged 40 to 60 with at least one cardiovascular risk factor. Morning types and evening types identified by a validated questionnaire and confirmed with 48-hour core body temperature monitoring, then randomized to either exercise at their preferred time, chronotype aligned, or at their non-preferred time, chronotype misaligned. 12 weeks, supervised moderate aerobic training, 5 sessions per week, 40 minutes per session. Same protocol, different clock. Per the reported results, the chronotype-aligned group saw substantially greater systolic blood pressure reductions than the misaligned group. Diastolic BP also better in the aligned group. Heart rate variability, a marker of autonomic balance, improved more. VO2 peak improved more. LDL dropped more. Fasting glucose dropped more. Sleep quality improved more. Same exercise volume, same intensity, different timing relative to circadian biology, and the blood pressure effect was nearly twice as big. Caveats: small trial, single center in Pakistan, short duration, we need replication in broader populations, but the underlying biology makes sense. Circadian alignment affects sympathetic tone, cortisol rhythms, melatonin, skeletal muscle mitochondrial function. Exercising in sync with your circadian peak is going to produce different acute and chronic adaptations than exercising against it. Clinically, this is actionable. Most type 2 diabetic patients struggle to exercise consistently. Telling a patient who hates mornings to go to the gym before work is a recipe for non-adherence. If you can match the prescription to their chronotype, they're more likely to do it, and now there is emerging evidence they may benefit more when they do. In your next clinic visit, when you're counseling about exercise, ask, are you a morning person or an evening person? When do you naturally feel most alert? Then prescribe around that. It costs nothing. It might amplify the benefit. That's your week in diabetes and endocrinology from Hormone Insight. If you found this useful, share it with a colleague. And if you disagree with anything I've said, I hope you do, because that's how we get better. You can find show notes with all the references at hormoneinsight.com. Until next Thursday, keep questioning the evidence, keep learning, and keep putting your patients first. Thank you for listening.